Good afternoon. I'm Annie Hanford. I am the Total Wellness Project Coordinator at Urban Pathways. And we're going to talk today about supportive housing, resident engagement, and wellness programming. I am a certified health education specialist with a Master of Public Health background. This is my colleague.
Hi, I'm Nancy Southwell. I'm Deputy Executive Director of Urban Pathways, and I'm a social worker by training. Annie's going to start sharing our presentation. So to tell you a little bit about Urban Pathways is a social service organization located in New York City, which is really oriented to work with people who are homeless and mentally ill. Our program, we have a variety of programs, including drop-in centers, safe haven, transitional housing programs, and permanent housing. But the goal is really to work with people that are currently homeless, help them get housed, and provide them with wraparound supports. Just like we have a diversity of programs, we have a diversity of people that we serve. While everybody is homeless and the majority of them have a mental health or substance use background, we also serve people that are veterans and serve justice-involved individuals. At Urban Pathways, a few years ago, the leadership of the organization was noting that we had a high rate of medical incidents, including ER, 911 calls and ER visits, and in particular, there was an outlier at a program in the Bronx, and so the organization developed a response to that, and we started a pilot program which we called at that time the Medical Wellness Program, and really the goal of the program is really to try out different interventions and see what works, with the goal of having better health outcomes for our clients and less reliance on and reduction of incidents. So in 2018, after a couple of years of doing this program, in particular at the Youth House program in the Bronx, we expanded the initiative to 3 other programs. All 4 programs house about 50 adults. They are all licensed by the state of New York, the Office of Mental Health. And so everybody that lives in these programs has either a history of homelessness or a history of institutional living, whether that be a long-term hospitalization in one of the state psychiatric centers or incarceration. So each adult has a serious mental illness, and many of them also have substance use issues.
So wellness is not just about diagnoses and treatments. We envision wellness as multiple interconnected dimensions of our lives. And you'll find this is similar to SAMHSA's definition. This definition includes, but is not limited to, physical health, disease management, fitness and exercise, interpersonal relationships, nutrition, mental health, spiritual wellness, sleep hygiene, stress management, and personal development. This is to give you an idea of the residents that we serve. They are 69% are male, 61% are Black and African American, 25% are Hispanic or Latinx, and 62% of our residents are over the age of 50. So we are serving an aging population. And now I want to introduce you to Robert. Robert is a 61-year-old Jamaican-American man who's diagnosed with schizoaffective disorder and borderline personality disorder. He smokes and is overweight, but he walks a lot. Robert was recently diagnosed with type 2 diabetes and hypertension. He takes his oral medications reliably and attends health education groups regularly. Robert is easy to engage, but slow to make behavioral changes. He eats a lot of his meals from the bodega across the street from his residence. Robert doesn't see a need to change how he eats because he feels fine and the sandwiches across the street are cheap. And we're going to revisit Robert shortly.
So there's a lot of literature, and some of it is referenced at the end of the presentation on the close to the last slide, about the high prevalence of medical issues among people that are homeless or have a history of being homeless. And there's also a lot of literature out there that speaks to the comorbidity of health problems among people with serious mental health issues. So we know that exists, and and we know that there is this high rate, and that they suffer disproportionately. But to think about the reasons why, or the contributing factors of that, when people are homeless, and people that are homeless are generally of very low income, it's very difficult for them to maintain, for some cases, to maintain health insurance, to maintain connections to primary and specialty care. People tend to move around a lot. They don't have a safe and stable place to keep their things, and so medical records are lost. Medications are not refilled in a timely manner. They may not have the proper place to store medication and to keep it safe. There's also behavioral issues, right? Or lifestyle issues that greatly affect health. So having poor sleep hygiene, not having a safe place to sleep, or a feeling of safety when one sleeps, can contribute to poor sleep, which then contributes to poor health. Not having the ability to maintain or manage a healthy exercise routine, and dealing with high levels of stress on an everyday basis. There's also a lot of literature out there that talks about the high incidence of trauma among people that have been homeless, and also on how trauma affects healthcare and healthcare outcomes among individuals. So there's a lot of contributing factors as to why our clients, especially once they reach the age of 55 or over, as we just mentioned earlier, a large portion of our clients are aging in our program, why they have so many difficult health issues. So we did an internal look at our data, and to look at how many comorbid, diagnosis individuals are managing at the same time. In our evaluation, we found that 53% of our clients or residents have 3 or more chronic disease diagnoses, and 21% have 5 or more. So every 5th person at our resident at one of our programs is trying to manage 5 different disorders at the same time. And when you consider that most of them have medication that are related to them, or special diets, then there's and doctor's appointments and specialty care appointments, that's a lot to manage for an individual. When you compare that to the general population, CMS reports that half of adults have at least one chronic condition, and that Medicare patients, who tend to be older or disabled, have 2 or more comorbid conditions at the same time.
Why are we so interested in reducing emergency department usage? Because the Healthcare Financial Management Association estimates that $8.3 billion is spent on emergency department services each year that could have been provided by other primary and ambulatory care providers. The Healthcare Cost Institute estimates the average cost of each of those visits to be almost $2,000. And unfortunately, unnecessary emergency department use by individuals with mental illness makes up more than half of this cost. So the Total Wellness program is focused on the improvement of physical and mental health outcomes for our residents. We aim to promote a culture of health and wellness and disease prevention through facilitating access to primary, specialty, urgent care, and mental health services, through managing medication, providing health education, improving or increasing health literacy, supporting appointment adherence, and reducing our residents' reliance on emergency services. Here's a handful of our Total Wellness program activities. We maintain community health partnerships for primary care, specialty care, and behavioral health. We conduct health and wellness assessments. We conduct education and training to support health and wellness and to develop our residents' independent living skills so that they can move on from our programs and move on to community living or other permanent housing. We do case conferencing to support residents with complex health needs. We manage the supervision of medication self-administration. We respond appropriately to emergencies and crisis care. And we provide a lot of ongoing training for our education for our staff. So wellness programming engagement really begins on day one. We want to emphasize that health and wellness are a priority here. So right away when a new client moves in, we do an initial health screen with them and we request their current annual physical. If they don't have an annual physical from the past 12 months, we'll schedule an appointment for them with our community partner. We document their medications and diagnoses, and we place them on the medication cart for the first 30 days. That means every time they take their medication, they're supervised by a nurse. After the first 30 days, they're assessed for their ability to take their medication independently and given support for whatever additional training or education they might need. And the resident and their case manager also work on creating an initial service plan where they collaboratively identify their goals and objectives.
So revisiting our resident, Robert, it is important to think about his presenting problems, but also his strengths as an individual and the things that are going well for him. So Robert's already demonstrated that he has a capacity to take his medication at the medication room without reminders. He's a regular. He gets there, each morning and each evening on his own. He rarely needs the staff to reach out to him in his room. So he has an understanding of the importance of medication, and even if he doesn't understand what his medication does for him, he knows that it's important to take it and that his doctor has recommended him to take it. Our plan is to make sure that we give Robert regular positive reinforcement and on his ability to use self-motivation to get to the medication room and to take his medication. And while at the same time, encouraging him and assessing him for his ability to take his meds independently in his apartment, because that would be the next step, right? So that would show if he's able to do that, and we certainly do not want to interfere with something that's working, right? But if we can encourage Robert to take his medication in his room independently, that will show more buy-in and from Robert. Again, Robert regularly likes to walk around the neighborhood. So he has he gets some enjoyment from being outside, from being in the community, and to moving his body. So the idea of getting Robert to join a gym, right, and maybe do doing some weightlifting activity might be too much of a stretch right now. But what we can do is we can encourage Robert to either increase his distance when he's walking, increase the frequency of his walks, or challenge him to increase his speed when he's walking. So, if he goes and walks around, let's say a 10 block radius, and it normally takes him, you know, let's say it's a mile, and it usually takes him an hour to do it, like trying to encourage him to take 45 minutes. So that he's more consciously thinking about his exercise and what it means and how it's making his body stronger. So another, a challenge is that Robert relies on the convenience of deli sandwiches. So, what's that about, right? Is it that he doesn't like to cook? Is it about the ability to fresh food in his neighborhood? So, we need to work with Robert one-on-one to find, are there healthy alternatives that are culturally sensitive, that are foods that he likes, that can be purchased at the bodega or other local markets. So what that will probably require is a staff member to go to the bodega with him and to weigh the pros and cons of a deli sandwich, versus maybe a frozen entree, a lean cuisine frozen entree, right? So to actually try to make some choices, to point out that the bodega does have some apples and oranges behind the counter. So, it really has to be a very hands-on, tactical experience. Okay, so Robert's also really good about going to his doctor's appointments, but only if a staff member goes with him and if transportation by cab is provided. So it's great that he goes to his doctor's appointments, and these are really important appointments to make. But we want to encourage Robert to be a little bit more independent in this. So we don't want to take the risk of removing that taxi service, for example, because without the taxi service, he won't go, and we need him to go. But maybe the staff member that accompanies him can coach him on asking more questions and being more engaged with the provider, so that he can learn more about his medical diagnosis and the recommendations. Robert's also a longtime smoker, and he really hasn't expressed a desire to quit. He acknowledges that quitting would probably make him healthier, but that's not something that's really on his to-do list. So the plan is to talk about ways that reducing the number of cigarettes smoked each week could have some modest health improvements, and to also discuss the availability of nicotine replacement therapy and medications. And that's a conversation that can include his healthcare provider as well. So as we've talked a bit about healthcare providers and community partners. And so one important factor of our model is to make sure that each of our residences, which we mentioned are in different boroughs of New York City, and so they're in different communities, all get connected with a local FQHC that can provide both primary and specialty care. So, we try to find and identify healthcare partners that we know are responsive to this community. Our community of homeless and formerly homeless individuals do face stigma in the healthcare environment, even among federally qualified health centers, and so we want to make sure that they have the services that could be supportive and responsive to the needs of our clients, and also provide a supportive environment for them. We also, form formal relationships with these providers so that we can exchange clinical information and get updated medical records.
Our healthcare education workshops, or health education workshops, emphasize engagement in healthcare services, taking an active role in one's wellness, and preventing the lifestyle factors that are linked to the development of chronic disease. So this is a menu, an abbreviated menu of some of the groups that we offer to the residents at our different sites. So here's some of the engagement strategies to get people to join our groups and meet with the nurse and attend their appointments. It's important that you know your audience. You need to know, the age, the needs, the interests, the backgrounds of the people that you're serving. We try to always make groups accessible and easy to participate in, so not overlapping with other events or regular occurrences in the residence. Maintain an inclusive culture. We want always for everyone to feel welcome and invited. We approach our clients with a helping attitude. We incorporate trivia and games because, we want it to be fun. We encourage, we mix up the setting and the format. So sometimes we go outside or we watch videos or movies or do Zoom meetings, but, try to make it a little bit different week to week. And we get regular feedback on people's interests, the themes of the group, the content of the group. Are they interested? Does it apply to them? And we, try to develop a reputation for being consistent and trustworthy and supportive. And then we need to sustain their engagement over time because our residents are generally with us for a couple of years. And we also want to increase their health literacy in these interactions. So we promote workshops verbally and with flyers to make sure that we reach everyone with the information. We provide visual materials with graphics and pictures, use plain language and physical demonstrations when appropriate. For example, if we're talking about oral hygiene or personal hygiene, physical demonstrations can be helpful. We, again, incorporate trivia and games. We always want it to be fun and use repetition to instill main points. And one of the ways we do that is with the trivia and games. We encourage dialogue and questions. We want a lot of sharing and interaction for people to feel more engaged. We use the teach back method where applicable. I like to ask people to tell me how to choose a healthy meal. What kinds of things will help them maintain a stable blood sugar. And then, not everyone's comfortable participating in a group. So we approach clients individually as necessary.
So a very important part of our model is to really help develop staff capacity in this area. And when I say staff, I mean staff of varying roles and titles. So that includes case management staff and other people that are more familiar with the social services, delivering social services. But it also includes our maintenance staff and our security staff because they have a lot of interaction with our clients. They can be wonderful role models, and they often are present at times of emergency, right? So we want to help them gain capacity in talking to staff about health, wellness, and crisis management. So we train all new staff and existing staff on our model. We also do a training called What Constitutes a Medical Emergency, and that's really a training that's both for staff and residents. And then some of our program leadership are involved in a motivational interviewing training model, which it will also help them train their staff reports and colleagues. So as mentioned, our What Constitutes a Medical Emergency is a training that was developed for both for staff and for our residents to help guide them when they're feeling unwell, and to make the decision about what is the best place for them to get the services they need for the given situation. We don't want people not to use the emergency room. We want them to use it appropriately, and we want them to be able to recognize that they might not have, that their circumstances might be better met at an urgent care facility or with a follow-up appointment with their doctor in a day or two's time. And we really want, our goal is really to help people get involved in preventative care so that the number of emergencies do get reduced overall. So our training really does include a lot of specific scenarios and asked, like, what would you do in this case? And then feedback is provided. We developed this magnet that we have distributed to our residents that they can put on their refrigerator so that they know and they can see very quickly, like, these are the things that I go to the medical clinic for. These are the things that are more appropriate for urgent care. And these are the situations that really require emergency room visits and a 911 call.
Here is a sample of the data that we collect on a monthly basis. Some of these metrics are required for our funders, and some of them are things that we monitor for program fidelity. But all of these measures help to tell us if our efforts are working. Some of our accomplishments from this past year are that 95% of our residents were connected with a primary care provider. 90% of our residents completed a wellness self-assessment that identifies their own wellness priorities. 70% of our residents attended at least one health education workshop. 42% of our residents completed an annual physical in the past 12 months. This is an area we're working to increase and improve upon. And the other 58% are not disengaged from medical care, but they are not yet on a 12-month schedule. But in the past year, we reduced, although we increased our 911 calls by 9%, we were able to reduce the emergency room visits by 30%. So we're making progress with this in these areas. And we also reduced the incidents that require hospital transport. So whenever a person goes to the hospital for any reason, by 8% from the previous year. And here's a list of the references that help to inform this presentation. Thank you, everybody.